For years, patients with GERD, gastroesophageal reflux disease, have faced a difficult choice. Rely on lifelong medication like proton pump inhibitors to manage their symptoms, or undergo laparoscopic surgery.
Endoscopic options such as TIF and cTIF offer an alternative. TIF, or transoral incisionless fundoplication, is a minimally invasive endoscopic procedure designed to restore the natural anti-reflux barrier without external incisions.
For patients with hiatal hernias larger than 2 centimeters, cTIF, or consecutive TIF, combines a laparoscopic hiatal hernia repair with the TIF procedure, all performed under a single anesthesia. Both techniques are now adopted in specialized centers across Europe, where they are increasingly recognized as minimally invasive alternatives for the treatment of GERD. So, let's start by looking more closely at TIF.
An ideal candidate for the TIF procedure is someone with chronic GERD symptoms that are not fully controlled by medication, a small or no hiatal hernia, and normal esophageal motility. These patients are typically looking for a minimally invasive alternative to surgery to reduce or eliminate long-term anti-reflux medications. There are several reasons why patients may choose an endoscopic option like TIF instead of relying on long-term medication. Firstly, TIF treats the underlying cause. By reconstructing the valve between the stomach and the esophagus, this restores its natural anti-reflux barrier function, unlike medication that only suppresses acid. Secondly, the procedure can reduce or even eliminate medication dependence. Many patients significantly cut down or stop taking PPIs after TIF, helping them avoid long-term risks such as nutrient deficiencies, bone loss, and kidney issues. Additionally, TIF can improve quality of life, often leading to better symptom control, fewer nighttime reflux episodes, and improved sleep and daily comfort. Furthermore, TIF is minimally invasive and supports a quick recovery. This is because the procedure is performed endoscopically with no incisions. Patients experience less pain, no visible scars, and a faster return to normal activities compared with traditional anti-reflux surgery. Moreover, TIF can also be cost-effective in the long run. Although medication may appear cheaper at first, the ongoing costs and potential complications linked to long-term use can make endoscopic treatment a smarter investment over time. The endoscopist first inserts the ESOFIX device through the patient's mouth and down into the stomach. Next, the device is positioned at the gastroesophageal junction using an endoscope for visualization. The top of the stomach, the fundus, is then folded and partially stapled around the lower esophagus. Fasteners are then deployed to secure the new valve structure, typically creating a 270-degree wrap. However, not all patients are suitable for TIF alone. Those with a hiatal hernia larger than 2 centimeters require a cTIF. So, let's take a look.
Studies show that patients with moderate to large hiatal hernias, typically more than 2 centimeters, experience greater and more durable symptom control with cTIF than with TIF alone. This is because cTIF addresses both components of the anti-reflux barrier, while TIF alone reconstructs the gastroesophageal flap valve endoscopically. It's only suitable for patients with no or small hiatal hernias. By addressing the hiatal hernia first, cTIF enables patients who were previously not candidates for TIF alone to benefit from a minimally invasive anti-reflux solution, helping them avoid extensive surgeries such as traditional laparoscopic fundoplication. First, comes the hiatal hernia repair. The esophagogastric junction is approached laparoscopically through small incisions in the abdomen. Next, the herniated portion of the stomach is gently pulled back into the abdominal cavity and dissected. Then, the distal esophagus is completely mobilized. At least 3 centimeters of intra-abdominal esophagus must be obtained. The opening in the diaphragm, the hiatus, is reconstructed with sutures, with or without mesh, to prevent future herniation. Once the hernia repair is complete, the TIF procedure is performed endoscopically to complete the recreation of the anti-reflux barrier. Most patients can then be discharged within 24 to 48 hours, returning to normal activities within a few days. TIF and cTIF are now recognized in clinical guidelines as effective, evidence-based treatments for GERD. Long-term studies show sustained symptom relief and a significant reduction in medication use. Studies show that most patients undergoing TIF or cTIF can reduce or even eliminate their use of proton pump inhibitors. This can improve their quality of life, avoiding the long-term risks associated with chronic medication use.
In March 2025, the American Society for Gastrointestinal Endoscopy updated its clinical guidelines to include both TIF and cTIF as recommended treatments for GERD. These procedures are now considered evidence-based options for patients with persistent reflux symptoms. TIF is effective long-term. A systematic review and meta-analysis published in Europe PMC found that TIF provides durable symptom control, with many patients experiencing significant reductions in heartburn and regurgitation for years after the procedure. In summary, both TIF and cTIF offer minimally invasive alternatives to long-term medication and traditional laparoscopic surgery for GERD, when compared to more invasive surgical procedures that offer faster recovery and fewer complications.